Hi friends, I'm Dr. Mayilananthi. In this session, we are going to discuss on tachyarrhythmias. So what is the objective of this session? At the end of this session, you will be able to find out the abnormal rhythm given in an ECG. For example, I have given two ECGs to analyze the rhythm. One is given here, the other one is at the end of the class. So what is the definition of tachyarrhythmia? It is self-explaining. Arrhythmia means abnormal rhythm and tachy means the heart rate is more than 100 beats per minute. We use tachycardia in place of tachyarrhythmias, but the two terminologies are different. We commonly use tachycardia when there is problem within the sinus node. There is increased rate in the sinus node. It may be physiological or pathological. Whether this rhythm is normal or abnormal, we don't see any P waves, and the QRS complexes, they are bizarre. Is there any tachycardia or not? So we have to calculate the heart rate. How are we going to calculate the heart rate? 300 divided by number of large boxes between two R waves. So how many large boxes are there? 1 and 2. 300 divided by 2, the rate is 150. Yes, this ECG shows tachyarrhythmia. We are going to analyze this ECG in a stepwise manner to find out the rhythm. This image shows normal impulse formation and conduction. Tachyarrhythmias can happen if there is problem in impulse conduction. Usually there will be re-entry. There will be circus movement of the electrical activity around a part of the heart. For example, around the tricuspid valve, annulus in atrial fibrillation. It may also happen if there is problem in impulse formation. For example, if the subsidiary pacemakers, for example, in the atrium, if it starts firing at a rate higher than the SA node rate, you come across tachyarrhythmia. The commonest cause for tachyarrhythmia is re-entry. This is the commonest cause in day-to-day practice. A simple classification of tachyarrhythmia is based on the site of origin of impulses. It may be ventricular tachyarrhythmia or supraventricular tachyarrhythmia. We are more worried about ventricular tachyarrhythmias because they are associated with poorer prognosis if not recognized and treated early. Supraventricular tachyarrhythmias are further classified as atrial tachyarrhythmia or junctional tachyarrhythmia. In junctional tachyarrhythmia, the impulses start from the AV node or the adjacent area. But the proper way to classify tachyarrhythmia is based upon the duration of the QRS complexes. So what is the normal duration of the QRS complex? It is less than 100 milliseconds. So if the QRS duration is less than 120 milliseconds, we are going to say it is a narrow complex tachyarrhythmia. If it is more than 120 milliseconds, we are going to say it is a wide complex or broad complex tachyarrhythmia. In narrow complex tachyarrhythmia, the impulses start from the atrium or from the AV node and they activate the ventricles simultaneously with a resultant normal or near normal QRS duration. In wide complex tachyarrhythmia, the impulses may start from the ventricles. The impulses will then propagate via the myocytes. It takes longer time to activate both the ventricles with a resultant prolongation of the QRS complexes. Or the impulses may start from the atrium or AV node. Then they will travel via an abnormal His bundle. That means the patient has either RBBB or LBBB, or there may be an accessory pathway. We are going to discuss about this accessory pathway later. So whether this ECG shows narrow complex tachyarrhythmia or broad complex tachyarrhythmia, let's calculate the QRS duration in V6. This is the beginning of the R wave and this is the end of the S wave. So what is the total duration? It almost occupies a large box. That means it is 200 milliseconds. So it is an example of wide complex tachyarrhythmia. These wide complex as well as narrow complex tachycardia are further classified based on the regularity of the QRS complexes. If the QRS complexes are going to occur at regular interval, we are going to say it is regular NCT or regular WCT. If they occur at irregular interval, We say it is irregular NCT or irregular WCT. So whether this one is a regular white complex tachyarrhythmia or irregular white complex tachyarrhythmia. So in rhythm strip, we are going to assess the distance between the QRS complexes. So they occur at regular interval. So this is a regular white complex tachyarrhythmia. First we are going to discuss on narrow complex tachyarrhythmia. We have already subclassified this narrow complex tachyarrhythmia into two types, regular and irregular. Let's discuss on regular narrow complex tachycardia. So what are the causes? Sinus tachycardia is the commonest cause for regular narrow complex tachycardia. It may be physiological or pathological. It has been dealt already. The second cause being junctional tachycardia, where the impulses starts from the AV node or the adjoining area. This has been already discussed earlier. So what are the other causes for regular narrow complex tachycardia? AV nodal re-entry tachycardia, atrioventricular re-entry tachycardia, atrial tachycardia, and finally atrial flutter. We are going to discuss these arrhythmias one by one. This image shows all the common causes for regular narrow complex tachyarrhythmia. First we will discuss on AVNRT. So what is the problem or where is the problem? There is problem within the AV node. Let's see what is it. In patients who are prone to have AVNRT, there will be two pathways within the AV node. This is a slow pathway which conducts very slowly but has a short refractory period. And this is a fast pathway which conducts fastly but it has a long refractory period. That means it takes some time to conduct another impulses. Normally, the impulses will be conducted via the fast pathway with a resultant normal PR interval. So, during the episode of AVNRT, what happens? An atrial ectopic occurs at critical time. So, this ectopic enters the AV node. And at the upper part of the AV node, it finds out that the fast pathway has not yet recovered after conducting an impulse. So, it will not conduct an impulse right now. So, the impulses will pass via the slow pathway to activate the ventricles with a resultant widening of the PR interval. In the lower part of the AV node, it finds out that the fast pathway is now ready to conduct an impulse. So, this impulse will go retrogradely through the fast pathway to the upper part of the AV node. From the upper part of the AV node, the impulses will be conducted back to the atrium to activate the atrium as well as via the slow pathway to activate the ventricles. This cycle goes on unless you are going to give some drugs to block the AV node. Here you have to see one thing, the atrial activity happens simultaneously with ventricular activity. So what is the implication of this one? So you will not be seeing a P wave during tachycardia if the patient has AVNRT. So the P waves are often hidden within the QRS complexes. So you don't see any P waves, or sometimes the atrial activity happens just after the ventricular activity. And the P wave will be abnormal because it is conducted from the AV node to the atrium. So there will be negative P wave in lead 2, lead 3 AVF happening after the QRS complexes. So this is known as pseudo S pattern. And there will be positive P wave in lead B1. You can see this one, no? So this is known as pseudo R dash. Next we will discuss about AVRT. So what is AVRT? It is atrioventricular reentry tachycardia. The classical example for this being WPW syndrome, Wolff-Parkinson-White syndrome. In Wolff-Parkinson-White syndrome, there will be an abnormal pathway known as bundle of Kent. So this connects the atrium to the ventricle, and this pathway has the property to conduct the electrical impulses. So the electrical impulses will be conducted from the atrium to the ventricles or from ventricles to the atrium. Normally, the AV node conducts the impulses from the atrium to the ventricles. The other part of the AV groove are electrically impermeable. So in patients with AVRT, The electrical impulses either enter via the AV node, that is known as orthodromic AVRT, or it enter via the bundle of kin, that is known as antidromic AVRT. First we will discuss on orthodromic AVRT. So in orthodromic AVRT, impulses from the atrium or from the SA node enters the AV node. This activates the ventricles. After activating the ventricles via the bundle of kin, the electrical impulses travel back to the atrium to activate it. Then it enters the AV node and the cycle goes on, unless you are going to give some drugs to block the AV node. In antidromic, there will be abnormal conduction via the bundle of kin to the ventricles. The impulses will return to the atrium via the His-Purkinje system. So what are the ECG manifestations? The rate is usually around 200 to 300 beats per minute. In this example, so there is tachycardia. You look at V1. There is some abnormality in the top of the T waves. So this is caused by retrograde P waves that is falling on the T waves. So whenever you come across tachycardia, and if you are not going to find out P wave, you carefully look at the QRS complexes, ST segment and T wave for any deformity. The deformity may be produced by superimposition of the P waves. Next we are going to discuss on ectopic atrial tachycardia. So there is atrial impulses formed, and these impulses will be conducted to the atrium to activate it, as well as the ventricles via the AV node. As the impulses start not from the SA node but from some other part of the atrial tissue, there will be abnormalities in the P wave. You must be knowing that P wave should be upright in lead 2, lead 3 and AVF. If the P waves are inverted in lead 2, lead 3 and AVF, you have to suspect ectopic atrial origin of the impulses. So, commonly this ectopic or focal atrial tachycardia starts from the right lower part of the atrium. So, with the resultant negative P waves in lead 2, lead 3, AVF. But when you look at the rhythm strip, all the P waves are similar. Even though they are inverted, they are similar. It means the impulses start from single focus. Finally, we are going to discuss on atrial flutter. In atrial flutter, the electrical activity will be moving around the tricuspid valve annulus. That is a typical atrial flutter. So, the impulses will activate the atrium as well as the ventricles via the AV node. So, what are the ECG changes? So, there will be regular atrial activity. It will be around 300 beats per minute. But not all the impulses will be conducted to the ventricles. There will be block at the level of AV node. So, there will be block within the AV node. The block may be in the pattern of 2:1, 3:1 or 4:1. If the block is fixed, you get regular narrow complex tachyarrhythmia. If the block is variable, sometimes it conducts with 2:1 block, sometimes with 4:1 block, you get irregular narrow complex tachyarrhythmia. To say atrial flutter, there should be negative flutter waves in lead 2, lead 3, AVF. Do you see? So, this is the negative flutter wave. It resembles sawtooth waves. So, in lead 2, lead 3, AVF, there should be sawtooth pattern. And in V1, you see upright flutter waves. They resemble normal P waves. So, when you come across an ECG with regular narrow complex tachycardia, you are going to look for P waves. If you are unable to find out the P waves, you have to suspect AVNRT. If the P wave is there, now calculate the atrial rate. If the atrial rate is greater than the ventricular rate, you suspect atrial flutter or ectopic atrial tachycardia. If not so, you are going to analyze the RP interval. So, what is the meaning of this RP interval? It means from the beginning of R to the beginning of P wave. During normal sinus rhythm, this is PR interval, beginning of P to the beginning of R. This is PR interval. You compare this PR interval with RP interval from the beginning of R to the beginning of P wave. So, during normal sinus rhythm, the PR interval is short compared to the RP interval. But during some arrhythmias, we have discussed about AVRT. The P wave happens immediately after the QRS complexes. So the RP is very short compared to the PR interval. So if the RP interval is less than 90 milliseconds, you have to suspect AVNRT. So we have discussed about regular narrow complex tachyarrhythmia. Now we are going to discuss on irregular narrow complex tachyarrhythmias. There are only 3 common causes for this one. The commonest cause for irregular narrow complex tachyarrhythmia being atrial fibrillation. There is no organized atrial activity. You see multiple atrial wavelets, but they don't activate the atrium as such. So there is no coordinated atrial activity, so there will be no P wave. But if there is no atrial contraction, there will be stagnation of blood. Whenever there is stagnation, there is increased risk of clot formation. This clot can dislodge, can enter any part of the body, either the systemic circulation or pulmonary circulation. If it enters the cerebral circulation, this leads to cardioembolic stroke. We have already discussed about atrial flutter. If there is atrial flutter and variable block at the AV node, you get irregular narrow complex tachyarrhythmia. The last one being multifocal atrial tachycardia. There are multiple areas of impulse formation within the atrium. But these impulses, they activate the atrium as well as the ventricles. To say multifocal atrial tachycardia, at least you have to find out 3 different PVA morphology. This is 1, this is 2, this is 3rd. You see all the P waves, they are different. This multifocal atrial tachycardia is commonly associated with obstructive airway disease like COPD, chronic obstructive pulmonary airway disease, and pneumonia. So when you see an ECG with irregular narrow complex tachyarrhythmia, look at the P wave. If the P wave is absent, you're going to say this is atrial fibrillation. So you don't see any P wave. This is QRS complexes T wave. There is no P wave at all. But sometimes you come across ECG with a coarse baseline. These are fibrillating waves but not the P waves. You should not confuse fibrillating waves with P waves. This happens in patients with recent onset atrial fibrillation. To say atrial flutter, there should be flutter waves in sawtooth pattern in lead 2, lead 3 AVF. And multiple P wave morphologies suggest multifocal atrial tachycardia. Now, we are going to discuss on wide complex tachycardia. So what are the causes for wide complex tachycardia? We have already divided the wide complex tachycardia into regular and irregular WCT. So what are the common causes for regular WCT? Ventricular tachycardia, this is the commonest cause, or supraventricular tachyarrhythmia with aberrant conduction. What is the meaning of aberrant conduction? There is problem. Either there is right bundle branch block or left bundle branch block, or there may be an accessory pathway. These are the 2 common causes for regular WCT. And irregular WCT may be caused by polymorphic VT. It means there are multiple foci of impulse formation within the ventricles, or atrial fibrillation with aberrant conduction. You know the meaning of aberrancy. We have already discussed that this ECG shows regular wide complex tachyarrhythmia. So what are the differential diagnosis? Either this is VT or SVT with aberrant conduction. Can we differentiate VT from SVT by looking at the ECG? Yes, there are so many criteria to differentiate VT from SVT. The commonly used one being Brugadas. So if you come across an ECG with regular wide complex tachyarrhythmia, look at the QRS morphology and compare it with the QRS morphology of the previous ECG that was taken during normal sinus rhythm. If both are similar, you say it is SVT with aberrant conduction. If the previous ECG is not there, you look for typical RBB or LBB pattern. If it is there, you are going to say SVT. If both are not there, then you are going to apply the Brugadas algorithm. I have taken only few points of Brugadas algorithm. You have to read fully about the Brugadas algorithm. It says you look for concordance. What is the meaning of concordance? You look at the chest leads from V1 to V6. You look at all the QRS complexes. Here, all the QRS complexes are negative or below the baseline. So, this is known as negative concordance. The second example, all the QRS complexes are above the baseline. You are going to call it as positive concordance. Uniformity, you can say uniformity. So, if there is concordance pattern, it is diagnostic of VT. If it is not there and you are going to find out any RS complexes, what we are going to do? If there is RS complexes from V1 to V6, you are going to assess the distance between the beginning of R. So, this is the beginning of R to the nadir of S wave. So, assess the distance. If it is more than 100 milliseconds, it is diagnostic of VT. And if there is slurring at the lowermost point of S wave, it is also diagnostic of VT. You have to apply all other criteria to say whether it is VT or SVT. So, what are the contributing factors? You look for AV dissociation. You must be knowing the terminology. The atrium. The star says atrial activity. So, these are the atrial activation. And these are the QRS complexes caused by ventricular activation. There is no relationship between atrial activity and ventricular activity. Atrium is contracting on its own and the ventricles are contracting on their own. No relationship between atrial and ventricular activity. If it is there, it is diagnostic of VT. And you look for capture or fusion beat. So, what is the meaning of capture beat? You compare these QRS complexes with this one. Compared to this QRS complex, this QRS complex is narrow and it is preceded by a P wave. So, what is the meaning of capture beat? It means during the episode of VT, the sinus impulse may be conducted via the AV node and temporarily captures the ventricle. That means the ventricle is activated by the sinus impulse. So, you see P wave, normal PR interval and normally looking QRS complexes. It is diagnostic of VT. And you look for fusion beat. What is the meaning? The ventricles are activated partly by the conducted impulses from the sinus node and partly by the ventricular ectopic. So, it is fusion between the two. So, in ECG with VT, you may also find out axis which is northwest. And you assess the duration of the QRS complexes. When the duration is more than 160 milliseconds, it is also suggestive of VT. So, we are finally coming to the end. So, whether it is VT or SVT with aberrant conduction. So, we are going to apply the Brugadas. Is there any concordance? No concordance. Some of the complexes are positive and predominantly here you see negative complexes. But you see RS complexes from V1 to V6. So, now we are going to assess the RS interval. It means from the beginning of R wave. So, this is the beginning, this is the beginning of the R wave to the nadir of S wave. So, 1, 2, 3, 4. So, it is more than 100 milliseconds. So, it is diagnostic of VT. So, when you come across an ECG like this, you have to alert your team immediately. Probably the patient may be having myocardial ischemia or infarct. You have to recognize it and treat it promptly. To sum up, so when you are going to see an ECG and find out that the rhythm is abnormal, so this is an abnormal rhythm. We don't see any P waves. Okay, this is an abnormal rhythm. You are going to find out the rate. So, how are we going to calculate the rate? Here the QRS complexes occur at irregular interval or haphazardly. So, here you cannot use 300 divided by number of large boxes or 1500 divided by number of small boxes between the R waves. So, you have to calculate the number of QRS complexes in 30 large boxes and multiply it by 10. This has been discussed already. So, how many QRS complexes are there? Approximately 14, and multiply it by 10. So, the rate is 140. So, this is tachyarrhythmia. So, first find out what is the rate, then whether the rhythm is normal or the rhythm is abnormal. If there is tachyarrhythmia, we are going to approach in stepwise manner. So, you are going to see whether this is a narrow complex tachyarrhythmia or a broad complex tachyarrhythmia. Let's calculate the QRS duration. It is less than 2 small boxes. Okay, so it is less than 120. So, this is a regular narrow complex tachyarrhythmia. If it is regular narrow complex tachyarrhythmia, you are going to find out whether the QRS complexes occur at regular interval or irregular interval. These QRS complexes occur at irregular interval. So, this is an example for irregular narrow complex tachyarrhythmia. What are the differential diagnosis? Only 3 possibilities. Atrial fibrillation being the commonest cause, atrial flutter with variable AV block, and multifocal atrial tachycardia. So, we are going to look for P waves if there is irregular narrow complex tachyarrhythmia. So, in the rhythm strip, we are going to look for P waves. Do you see any P wave? This is a QRS complex, ST segment and T wave, no P wave. QRS complex, ST segment and T wave. You see some coarse baseline, especially in V1, you see coarse baseline. They are actually not P waves. So, it is indicative of atrial fibrillation, probably of recent onset. So, this is about tachyarrhythmias. Next, we are going to discuss on premature ventricular complex. It is self-explaining. There is a premature beat starting from the ventricle and activate both the ventricles. We usually call it as ventricular ectopics. How are we going to find out the ventricular ectopics? You look at all the QRS complexes, 1, 2, 3, 4, 5, 6, 7. Of the 7, 2 complexes are abnormal. The remaining 5 complexes are normally conducted sinus impulses as manifested by P wave and are normally appearing QRS complexes. So, this QRS complex is broad. You calculate the duration 1, 2, 3. So, it is more than 120 milliseconds. So, there is a broad QRS complex and it occurred early. We expect the normal sinus beat here. But this ectopic has happened early. And you look at the ST segment and T wave compared to the ST segment and T waves of the normally conducted sinus beat. These ST segment and T waves are bizarre. These are known as secondary ST segment and T wave changes. Where do you come across primary ST segment and T wave changes? In patients with myocardial ischemia. And look for compensatory pause. What is the meaning of it? You are going to assess the distance between the sinus rhythm which happened before the ectopic and after the ectopic. This duration will be twice that of the normally conducted sinus impulse. So, where do you come across incomplete compensatory pause? In patients with atrial ectopic. These are the few terminologies used to describe ventricular ectopics. What is the meaning of unifocal ectopics? In a rhythm strip, all the QRS complexes will be similar. Okay, this means they have started from single focus. And multifocal VPCs in a rhythm strip, the QRS morphologies will be different. It means there are multiple foci within the ventricles. And what is the meaning of bigeminy? It is associated with digoxin toxicity. There will be a normal sinus rhythm, ectopic and a pause, sinus rhythm, ectopic and pause. This goes on. This is bigeminy. And in trigeminy, 2 normal sinus beat followed by an ectopic and pause. This cycle goes on. Thank you.